Welcome back, everybody, to another episode of Explain This. I'm with a new face on the show.
A new face indeed.
But a very familiar face to my life, and that's my brother here.
Ben, we were friends. We were best friends. We smelled each other's hands. We rode bikes together. We're quoting Four Christmases here. I'm your brother.
He's my brother.
I'm usually not on Explain This, and instead of going into medicine today, we're going to explain our history as brothers, okay? Let's buckle in.
No,
It's a bumpy ride.
We got an exciting topic today.
This is a good one. This is a really good one, actually.
Yeah, and every time, Explain This is always, I learn something new every single show we do, and today is one that you mentioned it to me before the episode, and I'm like, what in the world is that?
I thought we had already done it. And and this is really cool that we haven't done it because I think it's very prevalent right now. We talk a lot about autoimmune disease. Yep. We talk a lot about an overactive immune system. We talk about inflammation. So today we're going to talk about ANA,
which stands for
Antinuclear. I was going to make a joke. I was like, can I come up with a joke very quickly? No. Because when you Google ANA and you don't put anything after it, you'll get a lot of different search results rather than what we're looking for.
I actually tried that this morning. I got American Nurses Association.
Yeah. So I was like, ANA could stand for a lot of different things. But in medicine, and when you're talking about a diagnostic laboratory value, this is antinuclear antibody.
Okay.
Antinuclear. Say that 3 times. Antinuclear.
Antinuclear.
Antibody.
Antibody.
Did you hear that voice, ladies and gentlemen? Wow. We're going to harmonize that later. Okay, so antinuclear antibody. So ANA is a test that often gets drawn but doesn't get explained well.
Okay.
That's been my experience with it. And it's something that when you learn in school, in a medical school, a PA school, a nursing school, it usually means rheumatology or autoimmune disease. ANA, antinuclear antibody. So against the nucleus, antinuclear antibody. An antibody is like a defender in your body. So there's a lot of antibodies that are good so that it detects foreign pathogens. It tries to protect your immune system in your body against invaders coming in. When it's an autoantibody, it means that it recognizes something in yourself and attacks the body. It attacks the host. It does something it's not supposed to do. That is ANA. We're talking about autoantibodies. So we're attacking the nucleus of our own cells. Antinuclear, nucleus, the cell, antibody. So that's what that ANA actually means.
And when I think of autoimmune diseases, I do think when your body is attacking itself.
Yes.
And you're saying that this is a lab draw that kind of shows that?
Yes, yes.
Okay.
It's a lab draw that shows that, but it gets a little bit more complicated because if you're a patient and you've experienced this, or you work in rheumatology, you work in primary care, usually something that's going to tip a practitioner off to draw an ANA is signs and symptoms of an overactive immune system or an autoimmune illness. Fatigue, unexplainable rash, unexplainable fever, joint pain, inflammation, swelling, dry eyes, dry mouth, dry skin. You can tell someone that's been through autoimmunity. And what's so prevalent today is that a lot of people have autoimmunity and it's on a spectrum. So that's actually how the test is kind of laid out when you get it back on a result sheet. So whenever you get your labs back, it looks really complicated. And it's complicated for practitioners too, because ANA is not just positive or negative. It's negative or it's positive, and then it tells you a lot of other stuff about it. So that's what I wanted to explain.
So I can have an ANA, or a positive ANA, but someone else could have a more positive ANA.
Ben, it's like you're practicing medicine. It's like you're practicing medicine right now. Yes, that's exactly right. And actually, that's exactly right because 20 to 30% of the population can have a positive ANA, a very mild ANA that doesn't mean anything because you don't have symptoms. Mm-hmm. So it can be very common to have a low titer of ANA. Titer just means how much of it is in there. So they basically take this blood sample, spin it down, do its thing, send it off to the lab. Is it positive or negative? Yes or no. It's positive. Now, how positive is it? They start to dilute it in normal saline to different titrations. So they go Is it 1 to 40, 1 to 80, 1 to 160, 1 to 320, 1 to 600? It goes up from there.
Okay.
So it's basically, as you dilute it more and more, is it still present?
Oh, okay.
Does that mean, can they still see it after they do it? So
And that means it's stronger.
And that means it's stronger. That means you have a lot of it. It's a very positive ANA. So you keep diluting it. Is it still there? Is it still there? Is it still there? It's no longer there anymore. This is your titer. So we have a low titer would be a low or mild positive ANA. Does that all make sense?
Yes. Is that the language that a practitioner would use with a patient?
Yes.
Is low titer ANA?
Yes. Okay. Low titer are like mildly positive or moderately positive or very severely positive.
Okay.
So, and that's kind of the numbers they use. 40, 80, 160, 320, or 300, 640. 40, 80, 160, 300. It's either 300 or 320. I can't read my handwriting. And 640.
Okay.
So that basically means how sensitive is. Now, not how sensitive, how much of it is in there. Does that all make sense?
Yes. And when there's a lot in there, that means your body's attacking itself pretty.
It means there's a lot.
Severely.
The more that's in there, the more it's trying to defend. Remember, these are antibodies, so the more defenders you have in there. But it's almost like the defenders you've turned against your own team.
Got it.
Yeah.
Got it.
Yeah.
Okay.
So that's what a titer is. And then it's going to tell you the pattern. So it has a titer and a pattern. So these titers and patterns can kind of associate themselves with certain disease states within autoimmunity. Scleroderma, we're not going to go into specifics with this, but just know scleroderma, systemic lupus erythematous, or just lupus, Sjogren's, rheumatoid arthritis, mixed connective tissue disorder.
Are these all on the
polymyositis, dermomyositis, myositis meaning inflammation of the muscle, poly, a lot of muscle inflammation, skin manifestations with muscle inflammation.
Okay.
All these things mean where are you inflamed and what is it attacking? So autoimmunity can literally attack every organ. So you're trying to figure out as a practitioner and a patient, because patients can be their practitioners too. We don't know how you feel. We need to know how you feel. We want your input. So certain autoimmune disorders can have certain, like almost pathognomonic or very specific symptoms of how you feel. Lupus has a malar rash with fatigue and joint pain. Something called juvenile idiopathic arthritis, JIA, which has very specific symptoms too that include fever, that can kind of lead you down the path because you want to do something about it, right? You want to protect your immune system, kind of calm down the inflammation through different treatment modalities, which this is only about ANA today. Mm-hmm. So ANA is very sensitive. There's something with labs. There's sensitive versus specific. Say that with me. I'm just kidding, Vin. I'm kidding. I'm sorry. Say that with me.
Sensitive?
Sensitive just means that like it's going to pick it up. Like if the ANA is positive, it's ANA positive. It's not specific. So specific means that an ANA positive test does not mean you have lupus, does not mean you have scleroderma, does not mean you have mixed connective tissue disorder, JIA, whatever. Yep. It's or Sjogren's, another very common one. So it will just tell you that, hey, we're in the realm, we're in the ball field, we're in the ballpark, but we don't know where your seat is yet.
Okay, got it.
So it's like, oh, you're in the ballpark. You have a ticket. But where's your seat? I don't know what section you're in. Then it kind of sections it off.
And that's a follow-up test?
That's actually a really good analogy.
That is
it's
a great
like
analogy.
Ballpark, and then section can be titer, and then pattern can be what row or portion of that or of that ball field. So pattern, there's homogeneous, there's speckled, there's nucleated, there's centromere, right, and peripheral. Yes, so those are kind of the patterns that are associated with. And literally the pattern is, where does it sit on the cell? Is it all throughout, homogeneous? Is it speckled, like little speckled patterns? Is it on the centromere, on the DNA portion of it? Is it on the side, peripheral, or is it nucleated, like right only on the nucleus? So there's different ways that you can actually, and that kind of lets you know where it's going to be. DNA, histones, all that. There's anti-DNA, anti-double-stranded DNA, anti-histone. It gets very complicated after the ANA. But the ANA says, are we in the ballpark? Then where do we go from there?
But the ANA is one lab. It's
one lab.
One lab level. And then from that one level in the results, that's when you're getting into the rows and the seats and figuring out where in the ballpark you are.
Yeah, absolutely. Yeah, that's really good. That's true. So ANA can be positive for a lot of people that don't necessarily have disease state.
Right.
But it can also be very informative for people who do have symptoms, because we live in a very inflamed and toxic environment and world that we're seeing a lot more of it. There's over 100 autoimmune diseases. I think 106. That might be especially with COVID long haulers.
Yeah.
So to get specific about where you're going to go with it and how you're going to treat it depends on the practitioner that you have. What I like about ANA and getting more specific with it is actually saying, are we in the ballpark? And that's what I would explain to patients. We're in the ballpark. And this is what we can do. Your immune system is overactive. How do we want to decrease the overactive negative parts of your immune system while keeping the positive parts?
And so say somebody who's like, okay, maybe I should check an ANA. This is for anybody who has something that's unexplained, that, like you said, similar symptoms to an autoimmune type scenario.
I don't know what I have, but something's off. Brain fog, joint pain, unexplainable fatigue, swelling, rash, fever, tight skin, dry eyes, dry mouth. If you can Google autoimmune disease, and most people know something's off.
Yeah.
There is another test that we are doing now called AVISE testing.
Okay.
So ANA, you can draw through any lab, any standard lab, Quest, LabCorp, whatever. But AVISE testing is way more sensitive. And so I was looking at it this morning about the differences between an ANA from an AVISE versus an ANA from a Quest or LabCorp. It is way more sensitive and also gives you other markers associated with it. The problem with an ANA is that it'll come back positive, and it's 1 to 40. It's 1 to 40. It's homogeneous. It could be anything. And you kind of have mild symptoms. No one will do anything about that. Or rheumatology will either put you on a wait list, or they'll say, actually, we don't accept that. We need an ANA to be very positive. Okay. This AVISE testing couples a lot of other different autoimmune markers. Complement. They have something that's very specific called cell-bound complement activation products. So they give you an index for lupus rather than just the ANA. Because what happens is we try to guess as practitioners. Your ANA is positive. It's homogeneous, it's 1 to 40, it might be lupus. Let's draw the more specific ones for lupus. Then you get another lab test and you send it off to a different place. And then it comes back negative and they say you don't have lupus. You very well could, or you might have the prognosis to develop lupus. And AVISE testing gives you an index and an index score to say this is most likely what it is. So it can get you into rheumatology faster, or it can give you more information for an integrative practitioner like us to say, what do we want to do? Do we want to clean out your gut? Do we want to clean your nutrition? Do we want to incorporate low-dose naltrexone methylene blue? Do we want to actually send you to rheumatology quicker so that you can get on biologics or DMARDs, these immune modulators? So that's a more sensitive way and a little bit more specific to get a diagnosis with diving deeper into the ANA.
Super. It sounds like
Isn't that crazy?
No, it's a very powerful test, and
it's powerful.
It's very interesting how going into this, I didn't know a ton about it. Out of curiosity, how often are you drawing an ANA? Like, is this regular, or is it becoming more regular?
It's for us. I'd say for me personally, it's becoming more regular for me now.
Okay.
But starting off, no, because we're not rheumatology.
Right.
But now it's like, actually, we can do a lot of things functionally and from an integrated perspective with things like I just mentioned, LDN, methylene blue, parasite cleanses, because they say cleaning out and detoxifying the immune system can be through the gut. GI map, which will give you a little bit more specificity about overgrowth in the gut that you shouldn't be there, or opportunistic infections. We can do a little bit more with the ANA. What's nice that I've seen from a patient perspective is it's a validation. It's with AVISE. With ANA positive, sometimes it's a little bit of now I'm in a gray area. Okay, I'm in a ballpark, but what ballpark am I in? What do I do? And it's not positive enough. I've heard that from patients. It's not positive enough to do anything, and then it becomes scary. And then lupus can affect every single organ in your body. So it's how aggressive do you want to be? You can follow an ANA. So there's increases and decreases in titers of the ANA. So you can follow it with treatment.
So it does get stronger.
It can get stronger. It can be less. It can be weaker, stronger.
And I'm assuming treatment depends on the ballpark you're in.
Yes.
Or the seat in the ballpark.
Yes, or where you want to go. I say, yes, me personally, I would try everything before going on a biologic or an immune modulator. Because with biologics, immune modulators, that decreases all of your immune system. Though I do think those can be very life savings for certain patients. But there's a lot that you can do prior to. A lot of it is, I don't know what I have. I heard that last week is, I really want to know.
Yeah.
I want to know. And there's 106 autoimmune diseases with different markers. Anti-SCL, anti-Smith, anti-Roe, anti-Law, anti-double-stranded DNA, you name it.
Yeah.
So this kind of helps you give a little bit. Avise just couples it. It's 2 tubes. It's very easy. But ANA is the start. It's not specific. It's sensitive.
Andy, you explained it, man.
You're ANA.
You explained ANA.
Explain this. I am no Robin Riddle, but I'm proud of that one.
You know what?
You know what? I'm speaking truth into that, Ben. Here we speak truth. There ain't no fear here.
ANA, man. It was awesome.
Thanks. I appreciate it.
Guys, you name it, we explain it. Thank y'all for hanging out. As always, I hope you guys enjoyed this episode. As always, stay tuned. We'll get another video up soon.
Don't go away.